Ladies and gentlemen, our second keynote speaker today is Dr. Jelena Bogdan from Jacobi Medical Center, New York City. She is an assistant professor of orthopedics at Albert Einstein College of Medicine. Dr. Bogdan came to New York City at the age of 10 from Russia. She trained at the Boston Medical Center under the tutelage of Paul Tonetta, was the outstanding chief resident, was awarded by this as well. Dr. Bogdan is a recipient of multiple honors in fracture care, including the OTA highest resident honor, the Memorial Award. She's got an active interest in training and mentoring. She's very active on Twitter, always gives us tips and tricks on fracture care. I won't take much time, Dr. Bogdan. It's, over to you.
Thank you. Very good to be here. Now let me try and share my screen, and let me just make sure that you guys can see what I see. So let me do that. Okay. All right. Can you guys see that? Hopefully.
Okay, great.
Okay, that looks good. All right. Well, thank you very much for having me talk. And let me just move this out over here. And I hope this is going to be a combination of useful and fun. Mentorship is an overlooked topic, but one that I believe to be profoundly important to our profession. Here are my disclosures, none of which have any relevance to the talk. So my goal today is to talk about the importance of mentorship in your professional life as an orthopedic surgeon, from before residency to well into your attending life. I will also speak about some concrete mentorship strategies and how to avoid common pitfalls. Contrary to popular belief, effective mentorship is a learned skill and is not intuitive. It is different from giving advice or being someone's work friend and colleague. I start off with this slide because it is particularly important to look to the past to define what our work is really about and what our ultimate goal should be. This is from a treatise that was wildly popular in London in the 18th century. It was basically a layperson's guide to the treatment of maladies at home, because back then people didn't go to hospitals unless the circumstances were truly dire. For broken bones, they often relied on bone setters, which were not doctors, but basically lay people who had some rudimentary training in fracture care. And from this, we get the quote, "A small dose of learning with a sufficient share of common sense and a mechanical head." And that is what I strive to see in myself and the people I mentor as well, because it encompasses orthopedic trauma in particular quite well. So how do we get there? And how do we get to be decent doctors and surgeons in general? I take you to the Hippocratic Oath, and before the do no harm part, and by the way, primum non nocere actually doesn't appear in the original oath, at least not in those exact words, we have the first part of the oath here, the first and most important: to hold my teacher equal to my own parents, to teach them this art, to impart precept and oral instruction. So teaching is so important to medicine that it is literally the first part of the oath. Early doctors took this to heart. This is another treatise from the 1800s, which describes how young physicians should behave. And if you're not brushed up on your Latin, I will translate this for you. But even before that, take a look at the wording of the title: The Duties of Youth Apprenticed to the Medical Profession. The concept of the master teaching the apprentice is the key to learning medicine. And if that doesn't convince you, tirocinium means apprenticeship in Latin. So what does this mean for mentorship when it comes to surgery? Well, Ambroise Paré is considered the father of modern surgery. He lived in the 16th century, and as part of his early life, he was apprenticed to his elder brother, who was a barber surgeon in Paris. This apprenticeship was actually what distinguished medicine from surgery at the time, because physicians trained academically while surgeons trained in an apprenticeship model. So that relationship of master and apprentice, aka mentorship, has always been the key to the practice of our field. I can't do any talk on this topic without mentioning my own mentor, Paul Tonetta, and over the last decade, our relationship has evolved to resemble another great master-apprentice relationship that should be emulated, which is this one. And if anyone here is a diehard Star Wars fan like I am, you know what must happen for a Sith apprentice to become the master, so I always tell Paul that his time is coming. So mentorship starts to have an effect even prior to entering residency. In this study published in 2016, it was one of the most important factors that made students pick a surgical career in the first place. Here's another study of applicants to orthopedics specifically, where mentorship was rated as the highest quality factor in terms of deciding how to choose specific programs. So mentoring medical students has a very real effect on their comfort with the application process. When it comes to female applicants specifically, several studies show, unsurprisingly, that they make the same decisions as everyone else when it comes to being an orthopedic surgeon. The most important factors are related to number and variety of cases, fellowship placement, and camaraderie, and there is no effect of the gender of the faculty when choosing the residency program. This goes to show that the mentorship of any kind is important, and everyone who would like to be a mentor should be, regardless of whom you are mentoring. Mentorship can also potentially combat burnout once you are actually in residency. In this study, most US residencies did not have a formal program, and being unhappy with mentoring opportunities contributed to burnout, so good mentorship can affect mental health in residence. This is another study that suggested mentorship as a possible solution to fight the high burnout levels, up to 40% among orthopedic residents. The data is still unclear. Mentorship may also have an effect on overall resident satisfaction. This study polled attendees from the Resident Leadership Forum and found that the presence of formal mentorship programs improved satisfaction. However, there is bias potential because these are resident leaders specifically invited to this forum because of their proactive behaviors, and this group may have sought out mentorship opportunities themselves. This study showed that mentorship also has a significant effect on resident choice of subspecialty and fellowship training, with 75% of residents citing a mentor's influence on their choice. Here's another study showing that more than half of residents changed their subspecialty choice throughout the course of residency, and the presence of a mentor has a significant effect on that. In this table, you can see the highest scores in choosing a fellowship was experiences on the subspecialty rotation, intellectual interest, and experience with a mentor. So this might be especially important for more senior residents who are trying to figure out what to do with their career. For female residents in particular, again, subspecialty choice depended primarily on personal factors and interest in the specialty. And although mentorship played a role, the gender of the mentor did not. So this is another reason why the focus on mentoring should be non-specific and instead focus on providing mentorship quality and availability. How about after fellowship? This study showed that young attendings benefit greatly from peer and particularly senior mentorship. It makes them more likely to be satisfied at work, and it is important for career progression and research productivity, particularly when there are shared goals between the two attendings. This is something I have personally experienced, and it has been invaluable. This is a study from the UK on the same topic. New consultants did a structured survey, established consultants did an unstructured one. About half of new surgeons responded that they wanted mentorship from a more senior colleague, whereas older surgeons were a little more hesitant in their assessment of the relationship because they perceived some sort of competition from junior partners if they were in the same subspecialty. This is a mentorship error called begrudging, and I will talk about it a little later. Here's another larger form of mentorship, an international consortium of orthopedic trauma surgeons, which showed benefits particularly in the arena of outreach. So mentorship can be performed as part of a hospital department, a state medical society, or even a national society. Now that we've established the benefits of mentorship in our field, let's talk about how to do it and what exactly a mentor is. The word mentor implies not only guidance and counseling, but also acting as a role model for behavior. So professionalism and mentorship go hand in hand. In Homer's Odyssey, Mentor acts as a teacher to Telemachus, who is Odysseus' son, while Odysseus is on his journey. And Mentor is the personification of wisdom. He teaches Telemachus in his father's absence, emphasizing the importance of acting as a role model. This is a learned skill, and just because you have the desire to be a mentor does not mean that you will be good at it. So I will go through some published work detailing what it takes to be a good mentor. First of all, we will look at what a mentee, so the person you're mentoring, is. Mentoring does not mean you make someone into a carbon copy of yourself. The best mentors do not even need to be in the same field as you. My own mentor in med school was a vascular surgeon, and I have mentored many students who ultimately chose other fields. Your mentees may have different career aspirations, even if they are in the same field, and it is your job to help them develop what they are best at. It is not advisable to live your unfulfilled academic dreams through your mentees. Another thing a mentee isn't is a friend. This sounds harsh, but particularly in the resident attending situation, a true mentorship has a power differential. And while you can be friendly, you are not on equal terms, and you are acting in a leadership role to your mentee. They are looking for a certain level of professional guidance, and you owe them that. The friendship level will likely change with time, usually at the final stage, when the mentee becomes a colleague and the relationship changes. Pellegrini wrote an excellent article in Clinical Orthopedics and Related Research in 2006 about mentorship and the types of qualities good mentors have. More than anything else, good mentors are committed to the role. They are not fair weather mentors who only pop up when it's convenient for them. They are consistent in their role. They also have empathy, can work with different types of mentees, and as I said before, they are a role model in their professional life. They must also be able to transition out of the mentorship role when it is clear their mentee has reached that stage. In most cases, this happens naturally when the resident graduates. These are examples of bad mentors, and I'm sure you know someone in each of these categories, and some people fall into more than one category. First, there is someone who is not committed to the role and is very vague in what they can offer and unable to admit they may not be the best at something. Then there is the perfectionist turned tyrant who is perhaps overcommitted but has no empathy and cannot modulate their expectations to the mentee's needs. And I have seen this type the most in my life. Then there's the insecure egocentric who basically uses mentees to boost their own ego but doesn't offer them anything substantial in return. And finally, there's the begrudger, similar to that UK study that I talked about, who is worried about having the mentee become a competitor and is unwilling to relinquish their perceived superiority, even when the mentee is ready for that. So how do you mentor? The short answer is any way that you can. There are some published formal mentorship programs which are varied in scope and timing. You can even mentor long distance through various organizations that are always looking for physicians to volunteer their time via phone or email. A radiology attending published a particularly good way of training your mentees to be mentors to younger residents and medical students, thereby creating a ladder of teaching with exponential reward. If you are particularly passionate about clinical work, research, or another component of your career, you can mentor people only in that sphere. Basically, as long as you commit to the role, anything is better than nothing. On the opposite end, mentees can get the most out of their relationship by doing a few things. Initiation is often the hardest part, especially if you don't have a formal program. Mentees who know what they want out of the relationship and who have clear and objective goals and choose their mentors according to those goals are more likely to be successful. Good mentees also maintain the relationship by honoring their commitments and seeking feedback from their mentors continuously. As far as whom to mentor when it comes to surgery, unfortunately, the jury is still out. This article put a point on it, saying that lacking an objective yardstick, our decision to mentor is an art. And if choosing a mentee is an art, not a science, should you just find somebody who you think is similar to you? Believe it or not, there's evidence for that. This was a fun study of physicians who took the Harry Potter sorting hat quiz, and certain specialties did end up primarily in different Hogwarts houses. So there is something to be said about finding someone with a similar personality to you. And actually, something like this is already employed by businesses. And Paul and I published on this, the use of personality assessment testing in orthopedic residency, which was adapted from the business model. The idea behind this is that if you can match a mentor and mentee by personality traits, the relationship is more likely to be fruitful. Even if the mentor and mentee are not matched, knowing the other person's motivational drivers can give a mentor an advantage in counseling the mentee appropriately. This is particularly important for people who are outliers on the personality scale. And I direct you to the chart for an example. So Paul and I were the guinea pigs on the personality assessment test for this publication. And as expected, we're pretty similar. The red and black indicate our compatibility in regular work situations and are nearly identical. The blue and yellow lines are us as well, this time describing our responses to stressful work situations. And here, particularly important is the red circle, interpersonal sensitivity portion of the test, where each of us scored essentially 0. This is a significant outlier from the norm of 50. And if you have a mentee with such a large deviation, a test like this can offer suggestions of how to best communicate with that mentee. The box provides an example of a possible solution that was given to our personality issue. Be patient with others, try to choose the diplomatic course of action, which Paul and I both promptly ignored. While this sounds like a good idea in theory, personality testing has limitations. We don't actually know what constitutes a desirable trait in surgeons, and someone's personality does not always dictate their behavior. This is still not evidence-based, and certainly in these personality tests, there's also the opportunity to answer questions in an inauthentic way, basically trying to answer as an ideal resident rather than being honest about one's shortcomings. So while all of this isn't as concrete as the nuances of, let's say, femoral nailing or arthroplasty, I hope you got the essence of mentorship from this talk and maybe some ideas on how to incorporate it into your life. This is a good quote from a 2013 editorial called "Not Eating Our Young," to try to make a difference in the life of just a single person who shares our field so that our legacy is something to be proud of. And of course, to be a worthy mentor and teacher, we have to try to master our field as much as we can. This is one of my favorite quotes of all time from the great documentary Jiro Dreams of Sushi. You must immerse yourself in your work. You have to fall in love with it. You must dedicate your life to mastering your skill. And that is the secret of success. Thank you very much for your attention.
Thanks very much, Dr. Bolton. It's an amazing talk on mentorship. Great. So does anyone have a question? Neil, have you got a question? You just, came on the screen. Ms. Sangraj has got a question.
I do. Can you hear me, guys? Hello?
Yes.
Yeah, brilliant. So Yelena, that was really good. And we're trying to start a mentoring program officially in autumn. Can I ask you, who do you think was the better mentor? Obi-Wan Kenobi or Darth Vader? Sorry, or the Emperor?
Oh my goodness. Well, I think the Emperor's kind of out because, I mean, his whole point of mentorship is to just bring his apprentices up just enough so that he could kill them and then go on to a new apprentice when they became less useful to him. So I think he's out. I think that was Vader's original plan, if you read about some of Vader's own apprentices and what he was trying to do kind of on the slide. So I think Obi-Wan, I think I got to give it to Obi-Wan because at least he wasn't trying to murder his apprentices.
Thank you.
From Aman Mamazada, I'll let him talk. Aman?
Yes, I'm here. Thank you, Dr. Bogdan. That was a really, really interesting talk. I was just wondering, do you think that mentors should be assigned to people on the program, or do you think that this relationship should emerge organically?
I think there are, I think there's certainly a bonus in having an assigned program because it sort of helps people kind of get into that role in the first place. So let's say if somebody's kind of a little bit maybe nervous about getting a mentor, having an assigned mentor would help. But I think, so I think maybe mentorship program for younger residents should be a good thing. But to continue that, maybe for senior residents, I think those relationships should be more organic. Because I think forcing a resident into a relationship with an attending who may not match them, or when the relationship changes and the resident suddenly decides, you know what, maybe this isn't the right person for me to be mentored by, maybe I want to go with somebody else. I think there should be room for both kind of strategies within a residency program.
Great, thank you.
Mr. Bowdish has a question.
Yelena, hi, thank you very much. Questions about the specialty, or remaining within the specialty or going wider afield. I sort of look after 10 surgical specialties within the region. And we're sort of debating whether or not to have mentors from different specialties like you suggested, or whether to keep it within the specialty field. What's your comment on that? Thank you.
You mean within the subspecialties within orthopedics, or you mean going out to like general surgery or vascular surgery or something like that? Which one?
Yeah, the latter.
The latter, okay. I think if you have a surgeon outside of orthopedics who's a particularly keen mentor and understands what it takes to sort of direct a medical student in particular, the undifferentiated medical student, let's say one who hasn't decided, or even a resident who has some sort of interest in something else, like maybe for example, an orthopedic resident who has an interest in soft tissue work, so maybe a plastic surgeon could be a good mentor for them. I think absolutely you can go outside the specialty, because like I said, for me personally, my vascular surgery mentor was absolutely instrumental in helping get me into orthopedics, because he really showed me the differences between the two fields. And he said that orthopedics would be the better thing for me. And he was correct.
So in that sense, we should sort of build a bank of possible mentors that are available and allow people to perhaps choose or match as described. Thank you.
Absolutely. Yeah.
Daphne has a question. I'm allowing you to talk now, Daphne Chair. Right?
Hi, thank you for the talk. So I was wondering whether you think mentors and mentees should also match in other aspects other than personality type, for example, gender, perhaps race as well.
I think it's more how well you click with your mentor. If that aspect of your life is something that's important to you, let's say if you're more comfortable with a mentor who's of the same race as you, I think that's fine. But I don't think it should be assigned. Let's put it that way.
Do you mind if Mr. Kang, Neil Kang, has a question for you?
Hi, Elena. That was awesome. Thank you for being an inspiration as always. That question just there was from one of our medical students at Cambridge University, and you alluded to the fact that one of the greatest drivers of people coming into a specialty is mentorship. In America, is there a kind of a concerted effort by specialties like orthopedics to mentor the medical students?
Yeah, absolutely. I think I think some programs are better at it than others. There's definitely some bigger programs, like let's say the OTA or the AAOS, that has mentorship programs and opportunities for medical students to connect with mentors. But I think right now it's ultimately up to the individual program to kind of continue that. And there are definitely some programs that kind of make it a priority and others that don't. So in the ones that don't, the students tend to seek other opportunities. So I think it's a little kind of half and half.
So you've actually seen that, or there's evidence of the influence of having that affiliation to a program?
Yeah.
Great. Okay.
Yeah.
Work for us to do. Thank you.
Do you mind if Mr. Wasim Khan has a question?
Yeah. Right on.
You can go ahead, Mr. Khan.
Sorry, can you hear me now?
Yes, I can.
Oh, brilliant. So brilliant talk. Excellent. Thank you very much. Can I ask, orthopedic surgeons, we are quite a heterogeneous group with lots of different personality traits. Do you think there's any particular group of surgeons that shouldn't be mentors? As in, do they have undesirable traits, or should we just find trainees that fit in with those trainers and then mentor them?
I think given a little bit of my research on the personality stuff, just because somebody is an outlier doesn't mean that they are bad. For example, I would consider Paul a great mentor, and we clicked very well because we happen to be outliers. So I think just being different from everybody else shouldn't preclude you from being a mentor. But I think if you have any of the bad mentorship qualities that I talked about on one of my slides, and those become obvious with time, maybe not immediately, but at some point you're going to have feedback from the mentees saying, well, this person doesn't really respond to my emails, or they're arrogant or something like that. Then those people should be phased out. But I don't think anybody should be barred from being a mentor. I think anybody who has the ability and sort of the motivation and the time to do it, I think they should just do it and see how it goes.
Excellent. Thank you so much.
Are there any more questions for any even of the attendees or the panelists?
Thanks, Yelena, for a fantastic talk. Really enjoyed that. Thanks a ton.
Thanks very much for having me.
Thanks very much, Dr. Bogdan. I think you're off to your operating list now. You just finished